Hi, everybody. Module 4 lecture, chapters 31 through 40. I know that this is just a pullout of different slides, but please make sure you review all the PowerPoint slides for these chapters. Look at the end chapter questions and look at the vocabulary in each one. That'll give you the overall view of this module. We're going to start with some substances that are tested for that are often drugs of abuse. For instance, cocaine. We test for that. It's a anesthetic, vasoconstrictor. Um, it we test for it often in the laboratory. Other drugs that are of abuse that are tested for in the lab. Amphetamine, which actually has a pharmacological use in the treatment of narcolepsy, but there's methamphetamine, ephedrine, other things. So know these lists. Lead is commonly found in the environment. It's everywhere. Thing about lead is it can build up in your system and have a very bad toxic effect. And so we test for that when the symptoms warrant. Mercury is an interesting substance because in its elemental form it's non-toxic, but methylmercury, which accumulates in fish and substances and foods like that, it can you can get to poisonous levels where you get ataxia, impaired speech, vision, and hearing problems. So we test for that. We also test for substances that diagnose diabetes. Fasting glucose, for example, hemoglobin A1C, which measures your blood sugar level over a 3-month period because that's the length of time, the life of a red blood cell. So there are several different types of diabetes. There's type 2, there's type 1, and there's gestational diabetes. Now in type 1, which is 5 to 10% of the cases, the onset is abrupt. The patients are insulin dependent for the rest of their lives. Children, 90% of them that develop the type 1, test positive for insulin autoantibodies, meaning that their body is attacking the insulin that is produced, that their body's producing. And then we have heart, coronary syndromes. With heart, a major cause is atherosclerosis. We have cardiac biomarkers, and one of them is brain natriuretic peptide, or BNP, and we test for that a lot for cardiac patients. I would encourage you to look at the analytical considerations in figure 3411. It's reported in nanograms per liter, and it is very useful in clinical situations. Then we have glomerular filtration rate, which is to do with kidneys. It has to do with measuring the health of kidneys. It's a calculation, and it is calculated using the creatinine clearance. And creatinine clearance is a measure of how much your body creatinine your kidneys are eliminating over a certain period of time. Then we have the endocrine system. We have primaries and secondary endocrine functions. They produce hormones, a variety of hormones. So, and your endocrine system includes organs like kidneys, adrenal gland. Renin, for example, is synthesized in the kidney. Aldosterone is made in the adrenal gland. Got vitamin D. All of these are tested for in the chemistry lab. Remember the electrolytes from Module 3. We talked about sodium, potassium, and chloride. Well, sodium and chloride are measured, and they are used to calculate the balance of in the pH, the balance that your system is handling. And so an anion gap calculation is done for to determine your balance of sodium and chloride. Now normal results are 3 to 10 milliequivalents, have an example. Okay, a 50-year-old woman is admitted with a 2-day history of acute severe diarrhea. These are her lab values: sodium 134 milliequivalents per liter, potassium 2.9 milliequivalents per liter, chloride 108, bicarb is 16. So BUN is 30 and creatinine is 1.5. So this is how we do the anion gap. It's going to be the sodium 134 minus chloride plus bicarb. So that's 108 plus 16. By the way, I've never tried this technology before, so forgive my penmanship. Usually a lot better than this, but it was an interesting experience.
A few moments later.
So it'll be 124, as you can see there, subtracting that from 134 to get your anion gap. As you can see, 134 minus 124, which equals 10, which, as you recall, is the upper end of the normal range. So that is our anion gap example. Acid-base physiology, that whole balance of sodium ions and hydrogen ions, is all connected to healthy kidneys. Healthy kidneys will compensate for excess hydrogen ions by eliminating acid. And so that's where that anion gap calculation comes into play. Now we move on to the liver. Liver disease, there's a lot of different things: alcoholic liver disease, cirrhosis, cholestatic liver diseases, liver tumors, which, by the way, can develop from infections from hepatitis B and C viruses. So a lot of parameters, bilirubin and that sort of thing, are all tested for liver function. There's an approach to diagnosing when a transplant criteria is needed. So there will be serum albumin, prothrombin time, which is used to calculate an INR. That's a coag test. And then there's this transplant criteria called the Model of End-Stage Liver Disease, or the MELD score, and that's calculated from using the values, or it's monitored from the values of bilirubin, creatinine, and the INR. Now we have digestion, the gastrointestinal regulatory peptides. Everything is triggered by hormones, and different hormones start things and stop things, as you remember in physiology, like gastrin and secretin. That stimulates the GI tract, and the secretin stimulates pancreatic secretions. So everything is kind of a domino effect. Now, from physiology, you'll remember there's a digestive process. There's the neurogenic phase, which is initiated by seeing the food, smelling the food, you taste the food. When you ingest it into your stomach, then the gastric phase begins. That's when hydrochloric acid is released from the parietal cells and followed by gastrin. And then the intestinal phase begins when the food moves into the duodenum. Now, hormones regulating mineral metabolism comes from the parathyroid hormone. It regulates the concentrations of free calcium and extracellular fluid. I would encourage you to study the PTH measurements of it and the clinical significance in figure 39.3 in your textbook. Then we get to bone disease. There are several different bone disorders: osteoporosis, which is characterized by loss of bone mass, osteomalacia, rickets, Paget's disease, and bone malignancies. Hypothalamus regulation is the hypothalamus synthesizes both releasing hormones and inhibitory hormones. And there's a list here of different hormones, and I would encourage you to learn this list and be able to just know what each one does. Now, the assessment for anterior pituitary lobe. Why would they do an assessment? Well, there are clinically, it helps identify clinically significant hormone deficiencies and following surgery and radiation, irradiation. There's hyperthalamic, hypro, but hyperprolactinemia is the most common hypothalamic pituitary disorder. So that is the end of that module. Hope this is helping you all. Thank you.